And
Okay.
Kitty, if you want to turn on your webcam as well, the webcam button is at the main top in the middle above the presentation window.
Oh, okay. All right. Allow. Anything happen? There I am. Okay.
You may need to click start sharing. We can't see you just yet.
I need to click start sharing?
Yes.
Okay. I'm not going to give you any of my wine. All right. You tell me when to start.
Okay, well, first, I'd like to just thank everyone for coming to our IHI meeting. We do these meetings pretty regularly. We have usually a guest speaker. We have some kind of event every term. So we're really grateful to have you all here, and we hope you'll keep participating in the IHI. It's the Institute for Healthcare Improvement. So what could be better than that? What else could we ask for? I want to start off just by telling you a little bit about Right Care Action Week. So Right Care Action Week is what we're doing today, actually. We're doing a conversation cafe for Right Care Action Week as part of our IHI meeting. And we're looking at, if you look at this screen right now, you can see we're looking at the crisis in healthcare affordability. And that's the focus of this year's Right Care Action Week. So in particular, you can see on the screen, costs are too high, people are hurting, it's getting worse. And what we want to talk about is what we're worried about and ideas for fixing it. That's why we have Kitty here, to talk to us and to inspire us to get out there and fight. I couldn't possibly give Kitty a real introduction today. I couldn't possibly even list all of her accomplishments. It would take the whole 10 minutes. But the thing I want you all to come away from this knowing about her is that she has fought her entire life to improve healthcare. And whether that meant opening a school to educate nurse midwives and nurse practitioners, or running a practice, or all the things that she's done have been to improve healthcare. And so she's going to talk to us and give a little pep talk. We can do this. And it's our turn, actually. She's done hard work for a long time. It's time for the next generation to take over.
Oh, I'm so glad you said that. It is time for you to take over. Can you hear me?
Yeah.
Yes? Okay. I want to start by saying that I have fought all my life for midwifery. And because midwifery really set the stage for the development of all of the wonderful practitioners, nurse practitioners that have come along since then, and many of them being trained by Frontier in family nurse, mental health nurse, the DNP program, which is the developing nursing leaders and so forth. And so Frontier has always been on the cusp. But today, the crisis they're talking about is, in my humble opinion, I am humble sometimes, that if I look at all the other countries that have better outcomes than we do, the developed countries particularly, the one thing that's different, I'm sure they have just as good technology, just as good surgery, just as good neonatal care, all of those things. But what we don't have that they have is midwifery. And they right along with the development of medicine, and we really only developed medicine in this century. No, the past century, the 1900s. And so I think there's been enough demonstrations of this fact for the past 90 years. It says the same thing all the time. So I'm sick and tired of investing in any more research. I think we need to get on with it and develop the workforces we need. And the crisis is so enormous, it's affecting so many people that we can't just think midwifery, we have to think family. And we have to think then family, that's the grandmas and grandpas and the fathers and the aunts and the uncles, and it's everybody. And we have to think prevention, because the Frontier Nursing Service was heavily invested in preventing illness. So I'm not sure we're supposed to be talking about cost here, but I want to limit it to that, because I have a couple of things I want to share with you. The first one is I want to start with 3 words, and that is follow the money. And I want to end with 3 words, and they are follow the money if you want to know what's going on. Because we can't talk about cost in this country because we don't know what it costs. We only know charges. Our whole system is built on charges and payments that allow profit for the money handlers and the money controllers. And you see this, you can Google information on what does the CEO of Humana earn for a salary? Aetna. What does the CEO of Aetna earn? You can find all that on the internet. It's between $15 and $48 million a year. That's just for that one person. I wish I'd bought some stock in it. But anyway, so we are a capitalistic country, and socialism is a dirty word, but I'm not sure that we will ever take care of all of the people at a price we can afford if we keep going the way we're going. There are going to be more and more people who have to go without. If you're going to keep that percentage of the revenue going to where a few people are now approaching the billionaire status. And I suppose the billionaires will become trillionaires. So I want you to investigate the money. We need to be very careful about how we compare things. I know that in consulting with hospitals who are exploring incorporating nurse midwives in their services, or obstetricians practices that think they need to take on some midwives to help carry the burden, I always ask, in a hospital, for example, well, what is your budget for obstetrics? And I'm talking to the chief of obstetrics, and he says, a budget? I've never seen a budget. They have no idea of what it's costing to run their business within the hospital. And I'm not surprised. The hospital is very complex, because if you had a budget, you would have a line item, for example, for the number of parking spaces you decided you needed in the hospital parking lot and what that was going to cost you. You would have a budget for every single part of the hospital for the facility that you were using, for the nursing staff, for everything, for the meals that are served in your thing. I mean, that's just anybody that runs a household knows that. But they don't have it, and that's the person in charge. So what do we have? We have charges. Now, charges really don't mean anything, because the hospital or the physicians or whoever is in, they get smart after a while and say, well, we can't just bill for what it's costing us here, we have to bill for at least 50% more because they're going to take a 50% cut off our bill when they pay us. So that means that all your charges are not real. So it becomes a very complicated system. So, and I look at these things up at the end. You can find anything on the internet, you know. You can find the tax statements of a nonprofit hospital and see whether they're making any money, so they're reporting it anyway. And I say this to you because if you're a nurse midwife, I'm going to jump ahead now. The birth centers were started as an alternative to the medical model of care within the hospital. And the medical model of care, there's nothing wrong with the medical model of care when a mother needs it. What's wrong is that all of the women have to go there. And partly, I think, because if they don't have a certain census, they can't stay afloat. We've had 19 hospitals in the Philadelphia area close their obstetrical units. Now, that's a very risky thing to do because the obstetrical unit brings the mother and the family to their institution at that first time. And it's a known fact that a mother and that family go back to that hospital if they have been well cared for everything else they need their doctor in a hospital for. So that takes a big slice out of their marketing. And it's questionable whether some of them will survive. We have vast rural areas in this country that could never support an obstetrician because, unless of course they were taking out all the uteruses or doing some kind of surgery, because there isn't enough gynecological work to do, and there's not that many births in the rural areas like there are in the urban areas. So when you try to look at a solution, it's not simple. It's very complex. First birth occurred at home, always at home. It wasn't really until the 50s and 60s that we got all the women in the hospital. And it was a good introduction to families to medical care, but it was the medical care and obstetrics was being done by surgeons because that's what they're trained to do. At the same time, in 1950, for example, the mid-50s, a nurse midwife and a sociologist did a study, believe it or not. They asked 500 women what they wanted the nurses to do for them in labor, in pregnancy and birth. And in pregnancy, they wanted information. In labor, they wanted someone with them. They didn't care if it was a woman that swept the floor, but they wanted someone with them because, of course, the husbands and fathers were all told to go down to the pub and they'd be called when the birth occurred. They were not needed. And the third thing they wanted was their baby at birth. Just give me my baby. Well, we had all kinds of reasons for why we could not do that for them. You know, it's not sanitary. You're dirty, and the nurse says, I'm clean, and they march away. Those are very simple things, and we still do not give them to all mothers. So this is why you have the uprising of the women who finally got into the medical school libraries and began to read, and they wrote books like Our Bodies, Ourselves to tell us that we needed to reclaim our bodies. We didn't keep up with that. It's been, our bodies ourselves have been around for 50 years. So, and even today, women are having to march and carry banners and everything else to get anybody to listen to them for the simplest things. And I don't blame the doctors and I don't blame the hospitals. They're doing that. Blame is easy to throw around on everybody, and that's not the problem. The problem is, how do we get in this mess and how do we get out of it? Well, we need to look at the other countries, first of all, because they are doing a lot better. Their outcomes are much better than ours. And the only thing we're missing is the nursing midwifery. So that's why Frontier is on a mission. And that's why you're here, because you've been called. And that's why you have a responsibility for the next phase of development, which is to make midwifery care available to all pregnant women. So, where do you start? You say, where do you start? You start with first becoming as informed and educated as you can possibly be. And the midwives out there that are not getting educated, or they're choosing a way, an apprenticeship education, I feel badly about that, because their time and their money is being invested in something it's okay for if they're only going to take care of very normal women. Because you always have to remember, the women that don't have any problems, they could give birth without any of us. They wouldn't, and if they weren't made afraid, they'd probably enjoy it. But the key is that you be able to pick up those problems before they become a disaster for the mother and the father and the baby. And you bring in your medical model who has been trained to fix those. So you're working together. You have to do everything together. Nobody ever does anything alone. And midwives certainly do not, because they certainly can't do anything without the mother. So the home belongs to the mother. The hospital belongs to the physician. It's his or her place of business. And the rules there are going to be what they want them to be for their practice. It's very difficult for a midwife to practice in that setting unless they have set you aside into a midwifery-led unit, or what the Brits are doing now, which is a side-by birth center unit. The birth center was developed for the practice of midwifery, and it put, for the first time, midwifery on Main Street. It became visible, and it became talked about, and it's yours, but it's in its infancy. And if you don't protect it and you don't take advantage of it, it won't be here. That's one thing. But then, of course, I also understand you've got huge student loans to pay, and maybe you'll go into the into the hospital and work because they pay more. And it's only reasonable that you go in and get your bills all paid. But just remember, those three places of business require a different model of practice for the midwife. As a midwife, and this, I keep saying midwife because all health care begins with the care of the mother. Mary Breckenridge said that. So I'll talk midwifery, but it's the same thing for all the nurse practitioners and even the physicians. When you go for your job, I want you to be concerned to find out more than just how much you're going to get paid. I want you to turn around and ask them, what do you expect me to do for this pay? Do you understand what a midwife does? And am I going to be allowed to do it? Midwifery is time and education intensive care. And I see midwives in hospitals now with the orders coming down from administration that to see a patient every 10 minutes. Well, I'm afraid I'd have to say, well, I'm sorry that you don't want midwives. I can't be here. It'll take me 10 minutes to build any kind of trust with the mother so she'll tell me what the problems are. So it all depends on what you're willing to practice and what you're willing to put up with. Oh, well. So that went off for a minute. Is it all right? Is it back? So I want you to turn around and interview the interviewer and say to them, I am fully aware that in general, whether it's an obstetrician practice or a hospital, that 50% of the money I bring in goes to overhead. Okay? That means if you're going to give me $100,000 to work for you, and I'm talking about a reasonable life in terms of how much work, then I have to bring in twice my salary and benefits. So how am I going to do that? Can I do that? Because if I can't, I don't want to, be a burden to you. I want to be productive in your practice. I want you to make money because you built this practice. I didn't. It's a whole different dialogue that you're having. And I'm telling you, they will appreciate your understanding of the importance of the money. So I think I've used up my time. And so I want to say to you, my last 3 words are follow the money.
Kitty, thank you so much. It's so helpful to hear someone the perspective on healthcare and knows what this has looked like over the long term. So at this time, can you see the chat box? People are saying thank you and love you, and we all do. At this point, Janelle is going to send everybody into their breakout rooms. And so everyone will be getting a join a session box on the screen. So if you will click yes to join the session, then you will all you'll all be directed into the next room. Those sessions are going to last about 20 minutes, and then we'll come back here for a bit of a wrap up. And Kitty, again, thank you so much. It was great to have you here, and so good to have your perspective over the long range of healthcare. All right, we'll see you all back in just a few minutes.
main room now.
Yes, it's great to see you all back in the main room. So I would love to hear a couple of things about the individual rooms. Oh, good. Anna says that was great.
I thought it was difficult because we didn't know that there wasn't a leader, so we all kind of wasted some time waiting for someone to just speak up.
That can be difficult, definitely. Yeah, unfortunately, with the way that the breakout rooms happen in in the system, we all just kind of get randomly thrown in somewhere. So you're right. In my group, I did have to kind of assume the role of leader. But I'm glad that you guys saw that vacuum and eventually stepped into that. So looking, it looks like a lot of people had some things to say. Do you guys, does somebody want to go through I see you guys all typing things in the chat box, but this is a little more casual than that. We could have one person from each group just say something about what their group was like. Anybody from group 1 want to say anything? All right, so I was pausing a second to see if anybody was taking a second to get off of mute, but
I can do group room 2.
Okay, great.
Okay, so room 2, we had lots of different people. We had a lot of concern about some that worked in a federally qualified healthcare center, but the patients were not utilizing the preventative services that were offered. And we think that that's a good focus, is to do the preventative services that will help sustain and, cut cost. Another person chimed in and said that there was increased cost for insurance to actually have coverage, and that the current rate that we're going at is really unsustainable. And that's a big concern, is that it's just unsustainable at this point. Jacqueline Smith talked about that we're really out-of-pocket cost and, not having insurance or between insurances and stuff. And, people that need life-saving medication like insulin, and they can't afford it. And then Dr. Jefferson was talking about, the patients have a misconception about going to the ER, and it's free, and it's not free. Somebody's paying that cost, and it's not free. And then I had some concerns about our restricted APRN practice. I'm in Oklahoma, and we did not expand Medicaid, and we are the second state with the most uninsured people. So, yay, not okay.
I can completely sympathize with you as a Texan. And I see Mandy says they didn't in Wyoming either. Yeah, it's really hard as we work in this big, national audience. So often I will say something to a group and everyone will say, "Oh, but wait a minute, isn't that covered?" I'm like, "Oh no, not in Texas." So yeah, I feel you guys. Group 3. Anybody want to say something about Group 3's general, how your conversation went? Nobody from Group 3? Okay, then Group 4. Miriam, I see that you typed about it. Oh, go ahead.
Oh, that was great. Our group, we all shared, from our different unique perspectives from our different types of centers where we work and settings, about all the different kind of ways that we have interacted with the cost. And it is interesting in how each different site, kind of by its type, a lot of times does have a very different relationship with it, and how much you interact with that piece of it. Those of us who are at FQHCs, we come from a little different perspective. Those who are in private hospitals and those who are in like urgent cares and different things like that. And so we were discussing a lot of what that looks like and how different that is, and yet we're all affected by it in similar ways.
Yes, definitely. Group 5. Anybody from Group 5 want to tell us about your session?
I'll go ahead because I took the notes for us. We talked a lot about the cost of prescriptions and how patients will just stop taking them because of the cost. We talked about insurance companies kind of becoming the drivers of healthcare now and trying to tell providers what they can and can't do. We talked about immigrants and how their lack of healthcare can affect them. One person had a patient that needed dialysis and had no insurance, and basically the nephrologist told them they just needed to go back to Mexico. We also talked about the cost of health insurance, and Nurse-Midwife was sharing about how when new moms are talking about what do I do now with the baby, I've got to add the baby onto the plan, and how much the cost of that is to go from individual to family. And then we talked a little bit too about how sometimes patient demand will drive the cost of care up. Patients that come in expecting a lot of tests to be done, and people practicing trying to kind of cover themselves and not get sued for missing things. So then you end up ordering more tests than probably are needed. So, the right care goes both ways. Doing what's right, but not doing what you don't need to do.
Yeah, that's a great point. We didn't actually discuss that at all in my group, and I'm glad that you brought it up because it does make a big difference, giving the right care to the people who need it and not caving into the pressure from patients who are scared and need to fully understand, they need to fully understand what's going on and not just have lots of tests thrown at them. And that was Group 5. What about Group 6?
Hi, in Group 6, we had many people share their personal problems that they had with high costs of healthcare. And even with childbirth, there were huge costs to the mom and the family. People that were injured and out of work, we were concerned about it being the highest risk for bankruptcy in our country, medical care. And we were worried about denials of insurance coverage for things like MRIs. One person had to go for physical therapy when she already had and went through excruciating pain before she was able to get proper treatment. And we were concerned about pre-existing clauses, especially for people with cancer, that later in their life they may not be able to stay healthy if they can't get the services. And one person, I thought it was very astute that she's extremely worried about her children in the future, how much they'll have to pay for health care.
Yeah, absolutely. Big concerns. And I was in Group 7, but I would love for someone else to represent our conversation. Anyone from Group 7? Neander, would you like to do it?
So some of the things that we talked about in Group 7 have already been mentioned, but the rising cost of care for people in the future, how insurance companies are controlling what we can provide as far as testing and medications and things like that, and how it limits what we can do for patients, and their concern about how much is a test going to cost me, and we're not even able to completely provide the correct information because we just don't know.
Yeah, absolutely. When healthcare costs are so confusing that that we who are supposed to be experts don't have any idea, how to explain it, then how does anyone else have a chance? So we just have a couple of minutes left. So I'd like to take a second, first of all, for the groups, for those of you who are DNP students, and I think that is a lot of you, if you are DNP students looking for the extra credit, then remember to go into the Dropbox to look at the instructions. There's information there about what you need to turn in, what you need to do and when. And it's very simple. Mostly what we all wanted was for everyone to join the conversation. And then really quickly in our last couple of minutes, why is it important to join the conversation? Like all we did today was get together and talk. So who cares? Because we didn't actually affect any change. We didn't do anything tonight that changed anything. So why does Right Care want us to do this?
Because we're stronger in numbers. Like we're stronger as a team versus just one person.
And I think bouncing ideas off one another gives us ideas of where like to start, because it's overwhelming. It's so overwhelming because it's such a mess.
Yes, that's what I came to also when I thought about why do we even do this. I think it's because the system we have is perfectly designed to get the result it gets, and what it gets is a lot of money for a couple of people. And those people are not invested in change. Why would they want to do anything different than the way it's happening right now? And those of us who are invested in change it's so easy to be overwhelmed by it. I have never thought that this was something I could change. And when we get together in a group and we talk about it, when we go out into the community and we talk about it, I would encourage you all to look at options 1 and options 2. Things like Right Care Cafe or a listening booth. Just because you participated in this doesn't mean that you can't do these little and easy things to take the message out into the community. The more people who are thinking about this, the more momentum we have. And that's really what Right Care is trying to do, to build momentum so that we're all imagining that we actually could change something, and not that this system is just absolutely permanent, because, it's definitely not permanent. It is probably collapsing under its own weight. Mm-hmm. All right, so it looks like it is 9 o'clock Eastern time. I'm sorry. Yes, 9 o'clock. Sorry, I'm having to convert in my head. I want to thank you all for coming and for participating. Does anyone have anything else they want to say before we wrap up?
The Right Care Action Week wrap-up form, when we click on that, it says it's just view only and you can't type into it.
Is that the Google form?
Yes.
Okay. Anna, I believe you set that up. Are you able to fix that right now? Oh, she doesn't actually have a microphone on. I bet she is able to fix that right now. And if she's not, then we will get it fixed over the next, couple of hours by tomorrow, certainly.
Okay. And then what Dropbox do we put that in?
So in each of the courses, if you're a DNP student and you're looking for extra credit for participating tonight, then in each of the courses, 740, 741, and 742, you'll see a Dropbox within the course that says extra credit. And this is the only extra credit available. So it'll be the only thing you could have done.
Okay, under assignments.
I don't see an extra credit under grades in PC 740. I've been searching for it while you've been talking.
Yeah, and I'm in PC 711 and I don't see one either.
So I believe that the extra credit was only available in the DNP clinical courses. So that would be 740, 741, and 742. From my end, I can see it, but I'm looking in the grade book. I'm just looking under assignments really quickly to see where the easiest way to
I saw that Dr. Butler had it in PC 740, and you could submit either something written or an upload, but I can double check for you.
Okay, yeah, because like I said, I'm in 740 DNP student, and I've been searching this last couple of minutes in grades, assignments, everything, and I can't find anything. So I'll need more direction, please.
Yeah, I can't find it either in PC 740.
Okay, well, we will definitely, we'll look for it, and I can Well, I actually don't know how to get you more information about it, because the way that I will search for it is actually by going to the course and searching the same way that you will. Is there, if you aren't able to find it this evening, you can email me or Dr. Butler.
I know. So what happened was she posted the announcement, but she did not create a Dropbox. I'm going to create a Dropbox in PC 740 right now.
Oh, thank you.
Brent.
You create it in PC 711 as well. We were told to join for extra credit.
So the course coordinator for PC 711 will need to create that Dropbox. I don't have access to that Dropbox.
The instructor says students need to submit directly to me via email.
Yes. So if you'll look, Dr. Komorowski has those instructions there.
I'm actually doing ours for our group for 741, and I see where it is. But to email the form, I can't open the form either. I'm going to do it off my Chromebook, but I can't open the form to type it, to send it to email it to everybody.
So, so the form, are you talking about there's a Google form that doesn't have to be emailed to everybody, that actually just needs to be submitted, and Dr. Verzoni is going to update it so that everyone has access to it. It looks like it was maybe a read only, so we'll get that done by tomorrow.
Okay.
Just as a heads up, I actually copy and pasted it into a Word document, if anyone wants to do that in the meantime.
I have one last question. What's the signed release for? And where do we find the signed release?
So anyone who is submitting any pictures or anything like that to IHI needs to have a signed release. But if you're not submitting anything like that, you won't need to have the signed release.
Okay, thank you.
So do we not have
extra
to
credit?
Our picture?
Oh, I'm sorry. It does say a photo of you with so the signed release, if you click on the links, you'll find it. There is a signed release on the Right Care Action Week webpage, and I believe there's a link to it. I would have to click on all the links right now to find it, but it is there. And on the Right Care Action Week, all of these things are right there. They are all on one page together, very easy to access. And I would encourage you to spend a few minutes looking over it, because I think a lot of the real benefit in doing this is that we would be able to spread this message outside of people like us who are healthcare providers who are motivated for change. So even though you've participated in this, consider just talking to the people in your family or talking to a group of friends about some of the other Right Care Action Week ideas. If you have any other questions at all, or if this didn't answer all of your questions, feel free to send me an email and I'll help you figure it out.
Sorry, could you just real quick clarify that just one person per breakout group needs to submit the Google form, but then we all submit the Google Doc? Is that the case?
So there's a Right Care Action Week summary Google form that goes to the Right Care Alliance, and one person per breakout group needs to do that. Yeah, and if you're in the instruction sheet or if you're looking at the instructions, I'm reading that directly from the instruction sheet.
But it also says each participant should then upload the copy of the form to the extra credit assignment Dropbox.
Right. So one person submits to IHI and everyone submits to the assignment Dropbox. Because if you didn't submit it to the assignment Dropbox, we wouldn't know you were here, so we wouldn't be able to give you the points. All right. Well, again, thank you all for coming.
That makes sense. Thank you.
Thank you all for coming. I have enjoyed talking to all of you. I've gotten a broader perspective myself, and hopefully some of you guys are inspired. I'm feeling a bit motivated myself right now to take this message outside and get more people on board.
Sorry, I have one more question. Where it says event planner, is that like, do we just put who is in the group, or what are they looking for there?
Sure, you can put somebody who's in the group. I don't think that it matters very much. They're looking for somebody to be able to contact. So the person who's filling in the information would be the best one. And if you don't want them to have your info, you could certainly give mine. All right. Any other questions before we wrap up?
Yes, Dr. Meyer? One more question. I heard somebody say they were creating the Dropbox. So will that Dropbox be found in the assignment? Or would it be under grades?
This is Dr. Jefferson. I created a Dropbox in PC 740 that if you scroll down, it might be under IHI documents, you will find it. But when you go into Canvas and you go to the assignments, you scroll down and you'll find it. It says extra credit, Right Care Action Week.
Thank you.
You're welcome.
All right, thank you guys. I appreciate all of your comments and input. It was nice to spend this evening with you, and I look forward to seeing more of you in the courses. Everyone have a good night.